Welcome to the Nonprofit Report, your update on nonprofit organization issues and leaders, viewable on M. Oppenheim TV and YouTube. I'm your host, Mark Oppenheim, and today we're chatting with the team responsible for the Hospital de la Familia Foundation, which supports one of Guatemala's largest medical care organizations, with our special guest, Luis Guzman, Gerente General and General Manager of Hospital de la Familia in Nuevo Progreso, San Marcos, Guatemala. Susan Lindheim. Susan is an MD and is the organization's Maternal and Child Wellness and Education Committee Chair. She also is a retired pediatrician at Kaiser Permanente. Andy Sorenson, Eye Center Committee Chair. And Maggie Carlson. Maggie's an RN and is the medical team coordinator. So I'm so happy to have you all here. This is so exciting. And Luis, I'm going to go to you first because we're going to be talking about your day-to-day work. Every day you get up and you are ensuring that people in Nuevo Progreso and in the surrounding regions receive good medical care. Talk a little bit about your day and also the facility that you work in and the people that work with you.
Very nice to meet you. Thank you very much for the introduction, and it's a great pleasure to talk about Hospital de la Familia. Hospital de la Familia is an organization located in Guatemala, as you already described, has been established in more than 45 years ago. And it was initially established by an Italian priest who wanted to help people. And then he got joined forces with a person who knew about medical care, and then they were together working with a construction person from the San Francisco area, and then they came up with the very first building to provide health facilities, health services. After that facility was built, they got together with some medical missions from the United States that start coming to the hospital and providing care to the local people of this area. In those years, the area of Nuevo Progreso was a very large coffee plantation area. So there was a lot of people from originally the town, but also a lot of people coming from the highlands that were able to get services of the hospital. And the people that were invited to come from the United States, more of them general surgeons, gynecology surgeons, were also inviting some of their friends in their hospital that they were working, up to the point that the missions became one of the most popular medical missions in the region of the south of Guatemala and the south of Mexico, because we are bordering with Mexico. So I am from Nuevo Progreso. I grew up seeing all these missions coming to the town. And myself was benefited by having not personally surgeries, but my mom, my grandma, my grandfather, all my relatives got surgeries in this hospital. So that was the mystic of the hospital along the years that I was growing up. Up to now, the hospital has grown tremendously. I cannot exactly say a specific percentage, but I can tell you that the missions that are coming to Guatemala these days are much, much larger than they were at the very beginning. The other thing is that now we have local doctors doing the work that normally was being done by those missions. So I started working for the organization 5 years ago, and the way I describe the growth of this hospital is the same that is described in any other developing country. The facility was good enough when it was created 45 years ago, but now we have a larger human resources population, as well as larger demanding people from the community. Now we provide health services to probably around 100-kilometer radius of all the people in the country, as I said, including Guatemala and Mexico.
Let me pause right there, because what I think is so interesting, Luis, is your own reference to growing up in Nuevo Progreso. it's your own reference to your parents receiving care.
Yep.
It's your own reference, your own lived experience of having seen this place from nothing to where it is today. And now 5 years ago, you joined and you led. So Maggie, how long have you been involved with the organization and that story that Luis described?
So the first time I went down to the hospital was 2017, and I went on a team, went down to the hospital, didn't know anything about it, fell in love with the hospital. Went again in 2019, and then thought, I would really like to work for this foundation. And so started the process of just trying to find a job that would work. They hired me 2.5 years ago, and for a job that really didn't exist at that time and that has grown now. I coordinate medical teams that go down. It used to be these trips were 5 times a year with big teams of 50 people. And that has, with Luis and the direction of the hospital in what they need now for that region and to have the hospital really survive, is more frequent, smaller teams. And so that was what I was tasked with. And now we send 10 medical teams and 10 I teams down every year. And they're faster, smaller teams. And so the hospital has a more consistent presence.
And Susan, this is really important, because if you're talking about child and maternal wellness, a month is a long time, right? So if you're waiting for a quarter to elapse before your team comes there, that could actually result in a different health outcome for a mother and for a child, right?
Yeah, that's really true. But that being said, it's more about partnering with the hospital and less about us coming down, month after month and providing all the services. So
Right.
It provides a better partnership is what it does, and a more consistent partnership. And in addition to the teams going down, we also do grand rounds. So Andy will be able to speak to the grand rounds that he started and really that we followed the model of. And now that happens with the ENT surgeons, the pediatricians are available to talk by Zoom, to talk by WhatsApp, and to talk by phone, as well as the plastic surgeons. So anytime a team comes down, there's going to be availability with the surgeons after the team is down there and before the next team comes. So it's a really beautiful program.
Could you comment on that from your perspective, in terms of maternal child wellness?
So I first came down in 1998. I had a friend who was one of the team leaders, and they had a couple bad outcomes with children in surgeries and decided that they needed a pediatrician there. And that was, and at that point, there was the nutrition center. There were about 30 plus babies in this inpatient facility. Many kind of stayed for months on end. Were cared for by nurses, and there was not a pediatrician who particularly took care of them, but there were internal medicine people who kind of kept things going.
These were local internal medicine people.
Local, and it's
so this is 20 years after the original founding that Luis was talking about. You're coming in and you're seeing a different level of need.
Well, I don't know if it's a different level of need, but we're handling it differently. So now there are 2 pediatricians, Guatemalan pediatricians, who are there every day or most days. They have clinics, they do outreach. There's a nurse who's attached to them. There's a social worker who's attached to them. And we've really moved from an inpatient kind of approach to an outpatient, so that we go out to the community where education is being done. They now have weekly meetings every Thursday where 30 plus mothers and dads come and they get educated on certain things having to do with nutrition, baby care, et cetera. And so things have dramatically changed.
You talk about a different response, right? And as a matter of fact, in that brief description that you gave, you actually talk about how over some 20 years, some 25 years, some 26 years now, given that you started it, you said 1998, right?
Yes.
So what you're saying is that when you came, there were no pediatricians. There was a need for a pediatrician to come in. Now you've got pediatricians who work with Luis, who are local. And so has your role as a pediatric specialist and the role of those who come in from the outside, has that changed because you now have those on-site experts? And then we're going to get to the eye center, Andy, because it's a whole another level of different care. But Susan, has
the answer
changed?
The answer is yes. We used to do all the pre and post-op care for these children. Don't need to do that anymore. There's pediatricians who can do that. They've now connected with different groups, Guatemalan groups, for additional care, for physical therapy, for some speech therapy. We're now sending our kids who need cleft lips and palates to an organization which basically carries them through all the additional things they need, like dental and speech. So the kids are getting much better care. They're getting eye screenings now. We've given an eye screening machine. The mothers are coming in on those Thursdays and getting ultrasounds now on their babies and being dated appropriately. So lots has changed, but that's all being done now by the Guatemalans. So we now also have a Guatemalan OBGYN who is there as well.
Superb. And Susan referred to an eye screening machine, Andy. Talk a little bit about how you got involved and talk about what you've experienced in your arc of involvement.
Sure. So we've, my first experience in Guatemala was 1978. So I've been actually going there with my brother, my parents, and I'm kind of a family of ophthalmologists. And found ourselves first in Nuevo Progreso in 1987. And the mode of interaction from 1987 until 2015 was to engage in kind of the classic medical mission trip, which is certainly a valid way to deliver healthcare to regions of the world that don't have any type of access and no other recourse. So that's the methodology we were pursuing. But the numbers don't really add up very well. And that was very clear to us from the beginning. It's just you do your best and work your hardest as a visiting international team. And at the end of a year, for example, in 2015, we had 93 international visitors from the United States, nurses, ophthalmologists, technicians, translators, et cetera. We had 93 of those volunteers providing care for about 565 eye surgeries. So if you do the numbers, it turns out that it's about $1,000 a case in deferred income and costs of travel and costs of materials. And so it's just been really clear to us, my brother and myself, for decades, really, that's not the way to solve reversible and preventable blindness in Western Guatemala, Southern Mexico. And if you look at another set of numbers to consider that we've looked at very carefully is what is estimated to be a need annually just to stay current with the development of year-over-year blindness, reversible blindness. You need to be providing about 3,000 cases of surgical care, of cataract care per million in the population. And so Western Guatemala, where the Hospital de la Familia is located, serves a region of about 4 million people. And there are some other providers, but there's no other charitable medical facility, and there are no other charitable or non-charitable eye care or eye surgical care providers.
And it's the poorest region outside of Guatemala.
It's the poorest region in the Western Hemisphere, except for Haiti. If you look at childhood malnutrition, poverty, delayed access or limited access to healthcare, it's again, in the Western Hemisphere, it's the most profoundly needy. So that's what we're looking at. And what we realized at that point was that to tackle the problem, the solution was not going to involve more international volunteer teams. It was going to involve somehow training, educating, equipping, and attracting and compensating Central American ophthalmologists. And so that's what we pursued beginning about 10 years ago.
You know, you're making such an important point, and correct me if I'm wrong here, but in your analysis, what you're basically saying is that in the older model, which you have successfully implemented, the cost imbalance is that so much of the resources absorbed by the logistics of traveling to Guatemala, setting up at Guatemala, having translators in Guatemala for those doctors who don't speak Spanish. Whereas if you can have local on-site ophthalmologists, then the specialists can have a higher leveraged use, and the logistical costs are less because people are on site. Is that part of what you're saying, Andy?
Yeah, that's partly right. I think that's not a new insight. I mean, that's something we realized, 30, 40 years ago. If you could get Guatemalan or Central American healthcare providers to want and choose to live in San Marcos and deliver care, that's an obvious way to solve the problem. The issue is that people don't want to live there. It's remote. It's impoverished. It's not, it doesn't have access to technology. It doesn't have access to kind of modern medical facilities that they might find in the larger cities. Now, 30 years ago, that was a bigger deal, but it still is quite an issue still for not just healthcare providers, but particularly for subspecialists, which is what an eye care provider is.
If you look at an organization like Hospital de la Familia Foundation, they're making multiple investments. The easiest to understand investment is when you're investing in a microscope that you send in, and I understand there was just a microscope that was sent, or a team of doctors that you send, right? But let's say what you're doing is you're investing in better living facilities for the staff there, right? That investment might actually be a better investment than sending doctors on planes going back and forth. If you can attract more doctors to Hospital de la Familia, you'll end up with better care because it's locally provided, and it might actually, in aggregate, be less expensive to create the circumstances for local doctors to thrive. Right. Within Nuevo Progreso, which is what I understood your point to be, but maybe you weren't making that point.
Yeah, I think that's not quite my point. I guess where I was going to go with that conversation is that, prior to 2000, I mean, I'm just talking about the eye center, right? There's other programs going on at Hospital de la Familia, as we've already spoken about. But for eye care, the issue is the issue is that in Western Guatemala, we not only have to attract people to come there, but we have to provide some type of a carrot, some type of a hook that will help them decide to stay there for some period of time. And so what we pursued about a decade ago was a model of educating and training, mentoring, also equipping with contemporary technology, not just contemporary, but really the best technology available. And so if you look at what we've been able to accomplish there in the last decade, if you go down to there currently, what was initially one microscope and then two, currently there's 5 microscopes. The microscope we use for retinal surgery is better than the surgical scope that I have in San Francisco, California. When we go out and try to recruit ophthalmologists to decide that they want to come train and work in Nuevo Progreso at the Hospital de la Familia, we have to give them a reason to come. So we have our panel of reasons are that number one, we pay them a very competitive salary. When they are on site, we try to give them, as you mentioned, at least a comfortable place to live. I wouldn't consider it's very bare bones. It's just a bed and a bathroom, but at least it's safe and warm and dry. We also provide these visiting teams that Maggie mentioned, so that when they're there for 2 years, which is the commitment we insist on, they can expect that each month there will be visiting mentors from high-profile academic institutions in the United States to train. We send these doctors to the United States for international meetings and for month-long or 2 to 4 week-long rotations. They have access to the best equipment in the industry. So basically, the idea is that when we go out and try to hire people to come there, we want them to not just come and work, but also to, when they're done, feel like they have participated in one of the best academic and professional experiences that they could possibly have. And just to give you a couple numbers to think about, a typical ophthalmologist finishing training in Guatemala City may have performed somewhere between 10 and maybe on the higher end, 100 surgeries during their 3 years of residency training, and a fellowship that they might pursue also in Guatemala City might further add to their experience another 100 surgical procedures. Although I've heard some are as low as 20, some fellowships are as high as 200. But the fellows who come to the Hospital de la Familia and then work at the La Familia Eye Center for 2 years after their time, they're performing about 1,500 to 2,000 surgeries. So it's a type of training that's not available anywhere else in Central America. So when we started that model and started to build that out about a decade ago, we first had one ophthalmologist from Guatemala, then two, and our current panel includes 11 ophthalmologists from Mexico, Guatemala, El Salvador, Ecuador. We've had ophthalmologists from Honduras and Nicaragua. And that group of ophthalmologists are extraordinary. And so what was 565 cases performed by 93 international volunteers in the year 2015, this year it's 4,000 surgeries performed, mostly, if not nearly exclusively, by Central American ophthalmologists under the mentorship of a U.S. volunteer staff. So that's really what.
You said 4,000 annually?
This year we'll have 4,000 surgical procedures concluded at the eye center.
True.
So and we're not even, we're not where we need to be. We still need to triple that to be meeting the WHO's declared level of sustainable or meeting the need of the aging population.
Luis, when you take a look at what has been described by Maggie, Susan, Andy, and yourself, this has a huge impact on civil society in the region. And the thing that I still am trying to get my mind around is how you have navigated, and I don't mean you personally, but your people, the constituents, the people who have done everything from helping to drive a nail into a board as they're framing a house, to those who keep things clean, to those who provide the direct care as MDs. How have your people navigated the political vagaries of governmental changes, the changes in the coffee industry, which has hit that region pretty hard, the criminality that surrounds the area that takes advantage of people who live in need and poverty and all of that? How have you been able to maintain the steady progress that is all predicated on a certain amount of peace, collaboration, communal spirit? Why hasn't this fallen apart?
Well, as I was mentioning, and you already understand from the experience of them, now it looks like we are writing down a new history. All what they have described, it's something totally new for us. So we have very big challenges ahead of us. He just mentioned that it's so hard to make people come from a large city to come to this rural area where there is no good facility. So it is a challenge for us. So we are now trying to put two words together: the old history, the old model, which has been really good, together with this new model. And we just understand that there are a lot of challenges ahead. First one, answering your question, how can we make this strong enough so that it will not fall apart? So our strategy is, like Dr. Sorenson was saying, we have to create a structure so that all the pillars of our project can stay for the next 40 or 50 years, which goes to good facilities, good equipment, good environment, good education, and everything that makes people happy. In the
So
past,
sustainability first, right? It's sustainability is planned in long term. This isn't about spending a lot of money quickly in order to do something once.
no, because it's not about money. The main target here is human resource. Just what you asked, you know. Even if we have all the money in the world, we need to create the structure so that we can guarantee that this project is gonna function within the next 40 and 50 years. Is related to human resources. So what we wanna do is create a good environment so that the people feel very comfortable from the top level of the MD to the janitor in the hospital. And what I am creating currently are systems, protocols, structures that no matter who is in charge of this hospital, no matter with which organization we are working with, we are going to be able to move forward using our protocols and our system. And that's the key element, particularly in this moment.
So you're creating resilience, you're building in resilience, and you're planning for the fact that people will rotate in and out, but your
Exactly.
protocols retain consistency, right? Susan, isn't this the same kind of thinking that any maternal and child care organization must have in order to ensure that no matter who a person encounters as they come in for a visit, they receive that consistent care? This is really sort of a very foundational idea of consistency.
Right. We call it standard of care. And this is what is happening in Pueblo Progreso as well. And it's exciting. I mean, it wasn't like that. And as we find areas that we really are not doing the best possible, we're looking, Luis and the team is looking for connections and relationships with other organizations that will allow the children and moms of the area to get the best care possible.
There's another point here that I think that each of you has made in different ways, and that is that if you look at motivations, it doesn't matter if you're rich or you're poor, right? If your heart is failing and you need care, you need a place to go. In a sense, everybody has a stake.
That's right. And that brings up a really important topic as well, because part of our program, in addition to teams going down, is providing a better services for the community as a whole. And teams have done that by doing health fairs, or Andy started a fun run in the town where you should speak to that, Andy, where the community can sign up and on a morning do is it 5K run around the town. And so it provides not just surgical services, but holistic health care for the whole community as well.
It's so very interesting. I want to also talk a little bit about the idea of how decisions are made. In a resource-rich environment, people have the luxury of having a lot of specialists. And sometimes in a resource-poor environment, the thing that is the best investment is not to have a lot of specialists, but to have a lot of generalists. Luis, when you think about shaping your local practitioners, the medical professionals I'm talking about now, in a way that complements the visiting teams, and I'd like you all to comment on this after Luis gets his shot. Are you shaping your local teams in a way that makes them more complementary, where the local teams are shaped differently, fundamentally differently than the visiting teams coming in? And then I'd like you all to talk about how the shape of those visiting teams might have evolved over the years. But Luis, why don't you give it a shot first? Because it seems to me that given your ambitions to grow, you're going to be faced with that issue of who do you grow and how do you grow and what kind of talent do you cultivate?
Yeah, Dr. Sorenson already mentioned how they have been already doing it in the ICLIN. He mentioned that they have a weekly class, they present cases, and then they get advice and relationship with the very top level people from universities and from all the states in the United States, which in some way complements and makes feel these doctors in Guatemala, not only in the hospital, because they are from all over in Guatemala and Central America, very comfortable in coming in here. So this has been already done by more than 10 years in the eye center, and we are just kind of replicating that, and we are trying to provide new technology, being there. We are trying to lower our cases, like surgeries, when they come down to Nuevo Progreso, like when the American visitors come to Nuevo Progreso, and spend more time sharing, listening, what is the way we are solving our problems locally, and then understand each other and then find solutions together, in which means technology, knowledge, and experience from the locals. And then we are trying to put together, we are not thinking only about Americans or locals doing surgeries or doing their work, but doing it together. And that's one of our, I will say, the biggest goals for the future.
Knowledge transfer, right, Andy?
Yeah, I think if you look internationally at international humanitarian missionary work or mission work, or this idea of well-meaning medical volunteers and professionals going and donating time and service and resource to places of the world that have need, that's been a model for decades and decades, and it's a very successful model. It clearly has huge holes in it, and we've kind of touched on that today. The idea that the resource allocation of a volunteer leaving the U.S., traveling and doing a limited amount of work and then not providing follow-up, it's not a bad thing. I mean, there's a lot of really good that happens in those interactions. People are healed, they're cured, their sight's restored, their teeth are fixed, their hearing is improved. It's not a good financial model, but again, there's no other option in this part of the world for this population. And so this idea of a medical mission, though it does have, it does lend itself and open itself up to criticism, it is a really powerful model. And, we endorse it because there is no other option for many of the services that we provide. And I'll also add that model has a really beautiful impact on the volunteers. And so that's not something to be overlooked, because people who do give of their time, talents, and resources are blessed and touched, and their lives are changed. And who knows what impact that results in, right? What other good comes of their future lives of service. We really want to support
they who
that.
serve shall be served, right?
Yeah.
I mean, that's
but the second thing that I think is, again, with the Eye Center, that is, I think, is important to make this distinction, because it is powerful, is that with the Eye Center model of the sustainability and skills transfer, the other term we use is indigenized mentorship. We really are not going down at all anymore as international ophthalmology or eye service teams to provide care. We're just going down to support this model that we're all committed to. And, if the 10 ophthalmologists that we're training this year leave in 2 years and go back to their practices in the capitals and big cities of Central America, God bless them, because they're going to be the most talented, confident, well-equipped and trained surgeons in Central America. And so we see that what's happening at the Eye Center, particularly as transforming vision care in Central America. And if in Guatemala there are 18 million people, and we estimate there's over 100,000, 120,000 that are reversibly blind, and that number increases each year, we really have our plate full. And we are only going to reach we're only going to reach those goals that we have set for the region that have been set by the WHO by empowering, training, and educating this local team. So that's what we're really committed to. And so at the Hospital de la Familia, you really have two things happening, and it's on a spectrum. On one end, you have this full mentorship model of the locals providing care and being attracted to work there because of the education or because of the support, because of the environment they're in. And on the other end, you have, a surgeon from the U.S. traveling down with a nursing team and providing kind of a one-off surgical experience for those people who need it. And we're really doing both, trying to move the model more towards the sustainability model, this mentorship model, but recognizing that we're in this part of the world where kind of both are needed. And that's, I think, what is really unique about the Hospital de la Familia Foundation is it's recognized that both of these things are occurring. They're both really valuable and they complement each other in ways that are quite virtuous.
So one of the other things that the foundation has been very supportive of young people coming on these trips and being exposed. And personally, I had one of my sons come twice. He is now an anesthesiologist because of being in Guatemala, nothing having to do with me. And there are many, many stories like this. So we're also creating compassionate healthcare workers to work even in the United States. So it's another side.
And that's my personal story, was traveling there when I was 13 and seeing a cataract removed from a 10-year-old kid by my dad. And, this kid's sight was restored. And that's, that changed my life. And we see that happening in, time after time after time. So there is a real value that we want to continue to provide for international volunteerism, as long as we can as long as I contextualize it in what is going to be eventually the winning model, which is that sustainability and mentorship and skills transfer.
In 3 to 5 years, what is the biggest progress that you wish to have achieved?
A new building, for sure. Some new construction. I think that the main operating room area is in disrepair. I think the building needs to be revamped. And I think the eye center needs to double or triple in size to really get the job done.
Wow. That's a nice menu. Susan, what is your priority for the next 3 to 5 years?
I think for me, the priority, at least in the area that I'm working mainly with, is that the Hospital de la Familia is very well known and respected, even in the smallest of towns, and that we are able to reach out to all of those areas and do what we're doing.
Outreach and engagement. Andy, what is your list?
Yeah, we have a pretty clear view of what our horizon should look like. And that is, again, we've reached about the 4,000 surgeries per year level currently. Our goal is to get up to 12,000 to 15,000 surgeries per year. We expect we'll be at that point by 2030. That's our goal. To do that, we need to probably quadruple or quintuple our space. Maggie pointed out a doubling, which we need almost immediately, but to really reach that goal and to be a regional eye center that's serving a population of 4 million people, we're going to need to grow. That's going to require construction of a new building, remodeling of our current facility, and probably some further expansion beyond that. And we're well on our way to doing that, but there's some exciting changes coming ahead and growth and opportunities that we're really engaged with, and we're quite optimistic about what that's going to look like.
Luis, what is your wish list locally?
Well, I have already said that just like they mentioned, a building and human resources grow. My biggest goal is to create all that structure, legal, administrative, financial, political structure that allows them all these physical and human resources grow. Because if we have all these people working, if we continue having all these teams coming, but if I don't meet regulation, if I don't have clear standardization protocols and system, it's gonna fail at some point. So my goal is to create all the infrastructure on all the areas involved in my management that allows this grow, because we definitely are growing and we need to get ready for that growth. But my concern is all the structure involved in that growth.
The thing that I find so admirable about everything that we've discussed and what we've learned about Hospital de la Familia and the Hospital de la Familia Foundation is the fact that each part of your organization is personally dedicated to learning from others within and outside of the organization. You are not reluctant to evolve in order to meet your objectives. That is an unusual quality. Most of us are sold on our past experience. And the thing that really is so impressive is that you use your past experiences from your childhood, Luis, from yours, Andy, Susan, Maggie. You use your childhood as a reference point, but not as a barrier to change, right? And you seem to always be willing to go into the unfamiliar space. Luis Guzman, gerente general or general manager of Hospital de la Familia in Nuevo Progreso, San Marcos, Guatemala. Susan Lindheim, an MD and the organization's Maternal and Child Wellness Education Committee Chair. Andy Sorenson, Eye Center Committee Chair. And Maggie Carlson, an RN and the medical team coordinator for Hospital de la Familia Foundation. Thank you so much for sharing your experiences. I feel like I've come away just a little bit wiser. And I mean, that's no big trick, but I get to sit at your feet, learn from you. Thank you so much for your insights. Thank you so much for your contribution.
Thank you.
Thank you all.